This November 2020 emergency radiology article from Dr. Francesco Alessandrino and colleagues from Boston, Massachusetts, reviews the imaging underlying intimate partner violence, defined as the physical, sexual, or emotional violence between current or former partners. A particularly acute problem during this COVID-19 pandemic, the authors begin with a review of the entity and describe the role of imaging and of radiologists in diagnosis and patient management. The table at the beginning of the article lists the non-fatal and fatal outcomes resulting from intimate partner violence, a number of which have an imaging component. The article offers a schematic of the role of the radiologist in intimate partner violence, including the issue of the radiology report. Beginning with craniofacial trauma, the head and face are the most commonly injured body parts in victims of intimate partner violence, with more than 88% of victims that present to the emergency room showing facial injuries. Soft tissue contusions are the most common injuries seen. The left mid-third of the face, over the zygomatic arch, is the most common location. Fractures most commonly involve the nasal bone, followed by the zygomatic arch and mandible. Cranial fractures require significant force, most often with a weapon or household object used to strike the victim. Dental fractures most often involve the incisors and maxillary canines. Fractures and sprains are the most common musculoskeletal injuries encountered. A significant number of intimate partner violence-related injuries occur in the upper extremities, in defensive locations such as the hands, wrists, and forearms, as these areas are hit when the victim tries to protect his or her body from the abuser. 25% of intimate partner violence victims present to the emergency room with injury-related obstetric and gynecologic findings, including failed pregnancy, subchorionic hematoma, retained products of conception, intrauterine growth restriction, low birth weight, preterm birth, and perinatal death of the newborn. The issue of pregnancy as it relates to intimate partner violence is complex, and the authors address this issue in the article. After discussing head and neck injuries, the authors describe thoracoabdominal injuries, which fortunately are uncommon, but nonetheless certain regions of the trunk, namely the shoulder girdle, posterior chest wall, and anterior abdomen, are considered target areas and should be considered a risk for injury. In a concluding discussion, the authors share that a recent study shows that screening and referral systems for intimate partner violence can be successfully implemented in radiology departments, thereby facilitating screening of a larger portion of the population for intimate partner violence. The authors acknowledge the lack of a reference standard, which in turn leads to significant underreporting of intimate partner violence. Eliminating intimate partner violence is part of the United Nations Sustainable Development Goals for 2030. Radiologists can certainly play a vital role in identifying intimate partner violence, although much work needs to be done. Injuries in a defensive location and target areas such as the face and upper extremities, a combination of injury patterns, fractures at different stages of healing, and discrepancies between the injury mechanism reported by the victim and the imaging findings should trigger consideration of intimate partner violence.